start with the proceedings today. First, I request Dr. Kartamuthu sir to present his case capsules in urology, followed by Dr. Ganesh Prasad sir on his talk on urge urinary bladder, restless bladder. Thank you.
Good morning to all. I thank the Almighty, my teachers and the doctors who treated me when I was not well, and to stand in front of you and make this presentation. And here I like to present two cases. One case is rare and very rarely reported in the literature. The other patient is an innovative procedure we have done in our department. It is the so I like to share these two patients with you. He's a 27-year-old unmarried guy, and he's had a RTA about 4 years back, and following which he had a spine injury and paraplegic. Sequentially, he had developed a neurogenic bladder. He is on continuous clean intermittent self-catheterization for the past 4 years. And he complained that he was not able to do CIC for the past 1 week. But he was voiding because of continuously overflow incontinence he was having. And we suspected that he is having a strictured urethra. So we did a ascending ureterogram which showed a wide-necked broad-based diverticulum with proximal urethral stricture. MRI was done to assess the exact anatomical location and extent of the diverticulum and whether there is any other coexisting problems within the diverticulum. So the MRI done and it confirmed the same, the diverticulum without any other problems within it, and there is a proximal urethral stricture was there. Did a cystoscopy which also showed penobulbar diverticulum with dense proximal bulbar urethral stricture. The diagnosis is adult acquired urethral diverticulum with proximal urethral stricture in a young man who does CAC for emptying the bladder. So we had our own management dilemmas. What is the best option and what is the best treatment solution for this guy? So one option is diverticulectomy with urethroplasty. So that we thought the stricture is very proximal to the sphincter and it may affect his continence. So the other option is the Mitrofanov procedure, because the patient is already on CAC. Even after correcting the diverticulum and urethroplasty, he will end up in CAC. So once for all, if he develops any complication after the diverticulum, what to do? So we thought we will totally divert the track. That is, sorry. So the Mitrofanov is appendicular stump is connected. One end is connected to the bladder, other one is brought to the anterabdominal wall as a stoma. The patient will be able to do a CAC through this stoma. And this because the patient is morbidly obese and he was having a lot of tummy fat. So we thought the appendicular length will not be sufficient, and he may develop stoma-related complications. So we didn't go for it. The other is perineal ureterostomy, total diversion, and since he is young, unmarried, and also he will be having a difficulty in doing the CAC through the perineal ureterostomy. So that also not opted. And another one is two-stage urethroplasty, where the urethra will be laid open up to the diverticulum and up to the stricture. It will be laid open and the graft will be placed. After 6 months, we will come back and do the reconstruction. And this the patient didn't prefer, and also he will not be able to do a CEC with this also. Then we thought we will go for a diverticulectomy with visual internal ureterotomy. So we did a cystoscopy and did a internal ureterotomy, guided and placed the 14-French silicon catheter, and through the penoscrotal incision, the diverticulum was open. It was dissected all around, and this is after opening the, sorry, I am misusing this pointer. So this is after opening the diverticular wall, you can see some changes seen in the epithelium, epithelial lining of the diverticulum. Squamous epithelial changes are seen. This is after trimming the diverticular wall on one side, the other side is left undisturbed. That is minimally trimmed so that it can be used for the reconstruction. Video play பண்ணோம். எங்க எப்படி வீடியோ இல்லையா? ஸோ this is the diverticular repair. This is after completing the urethroplasty. Double breasting is done and using the edge of the diverticular wall. The post-op follow-up, the patient recovered very well. There is no fever, no end infection, and 6 months follow-up, the patient is doing well, and no fibrility in between, and there is no urethroperitoneous fistula. The patient preferred to be on the long-term catheter than on CAC because he was taking an exam. The catheter changed it twice without any difficulty in the follow-up. So male urethral diverticulum is very minimal, very few case reports are there in the literature. The prevalence is not even estimated in this. The diverticulum may be a congenital or acquired. The management depends upon the length. Usually if it is a short, excision and end-to-end urethroplasty can be done. And if it is a little longer, we can do a diverticulectomy, trimming and double breasting as what we have done. And if the length is larger and the defect is large, we can do a substitution urethroplasty. This is another patient. He is a 23-year-old college student, Indian national, studying in New York. He came here for vacation and he was having a poor urine flow for 1 year. And he consulted a doctor in urologist in Chennai, and they have done a uroflowmetry which showed an obstructive pattern. And on clinical examination, he was having a glandular hypospadias. There is no meatal induration or urethral induration. Ascending ureterogram was done, which showed short segment bulbar urethral structure around less than 2 centimeter in length. The options in this patient is, one is excision and end-to-end urethroplasty. Other is VAU. The latest in the armamentarium is VAU plus autologous adult live cultured buccal epithelial cell therapy. The excision and end-to-end urethroplasty, we didn't opt in this patient because there is a risk of, though it is having a very high success rate, more than 90%, because it is located in the vulvar urethra, it may disturb with the vascularity and bulbospongious muscles will be disturbed, and he may have a chance of erectile dysfunction. So we didn't offer it. The other option is visual internal ureterotomy. It is a minimally invasive and endoscopic procedure, but the disadvantage is it is having a high failure rate and chance of redo procedures are high and need periodic dilatation and self-calibrations and need regular follow-up with the urologist. Since he is in, he has to go back to US for his studies, he may have the difficulties with the access to the urologist. So we thought we'll give a option of VAU plus Albert therapy. This is a novel and innovative therapy which has come.
It offers tissual, structural and functional restoration of the urethral structure, and novel and minimally invasive and regenerative solution. What is this tissue therapy or cell therapy? It's an introduction for it. It is a cells are autogenic or allogenic cellular material is transferred to the patient, and it regenerates within the patient's defective areas. It is a therapeutic area of interest in this cell therapy or regenerative medicine, immunotherapy and cancer therapy. The cell sources are autologous or allogenic stem and differentiated cells. It involves genetic engineering or formulation manipulations. Benefits of transplanted cells are it promotes rapid vascularization, enhances epithelialization and at the graft repair site, minimizes the scar formation and improves repair outcome. The cell grafts show more than 6 times long-term success rate than the scaffold alone. So what are the advantages of where are the grafts are taken? The grafts may be taken from the buccal mucosa or bladder mucosa or scrotal skin. Compared to other things, the bladder buccal mucosa is very easy to take the graft, and it is having associated with very minimal morbidity, and the epithelium is almost similar to urothelial epithelium, and it is having better adaptability to the wet environment. And the long-term success rate is more than 80 to 85% with the buccal mucosal graft cells. This is the actual picture of taken in our hospital. This patient, buccal 1 into 1 centimeter buccal mucosal graft was taken, and from the inner side of the cheek, and this graft was sent to Pune by flight. And there they manufacturing the tissue engineering and multiplication of the cells was done. And then the VAU and Albach implantation was done. Here this graft is placed in the medium and sent to the manufacturing site, where the epithelial cells are multiplied by tissue engineering, and more than 5 million cells are produced. And after that, once the product is ready, it is sent back to us, and it comes with the mixing solution, and the product will be mixed in the operation theater. It will have 1 ml of fibrinogen in one syringe, and another one will have the Albach solution with the thrombin. The both are connected to the tubular jet syringe. And actually how it is being done, the patient is in the lithotomy position, cystoscopy done, and the stricture is visualized, and the stricture internal ureterotomy is done, and at the internal ureterotomy site, after the internal ureterotomy, the catheter is placed, there is a traction given, and a small size ureteroscope or the nephroscope passed along the the catheter, and in the scope's working channel, the ureter catheter will be passed, and the mixed solution Duplajet, through which this tissue engineered cells with the medium is injected. It forms a scaffold around the catheter and closely adherent to the urethra at the stricture site. Sorry, this is also not playing.
The catheter is placed and the scope is passed along the catheter and the stricture site is seen. Here the catheter's traction is given at the catheter. This is the scope that is passed along the catheter. This is the stricture site after the VAU.
So now we have placed the ureteric catheter in the working channel of the scope. This is a ureteric catheter that is being passed through the working channel, and this is the ureteric catheter at the side of the stricture. This is the Albeck. The tissue is being prepared. So to connect it to dupla jet syringe, and the ureteric catheter is at the side of the stricture incision site, and the tissue is the tissue engineered cell is being injected. So this is the fourth case done in Tamil Nadu. The patient is happy. There is no open surgery. Follow up in 1 week is the flow is excellent. No urethral calibration or urethral dilatation is needed or done. Uroflow entry in this patient. Before surgery, we can see it is very flat, maximum 6 ml per second here. It is almost like 26 ml per second. This is excellent outcome where VAU with Albeck. So it is not widely done. There are only 4 centers which are doing this. But it's an option for soft segment, bulbar urethral stricture. It's gives a ray of hope for young and sexually active men. Thank you. At this juncture, I want to tell one thing. That is, we used to be called for a lot of catheterization, post-catheterization related injuries after catheterization, urine is not draining like that. And we have I appreciate the teaching faculty of the nursing students, and we have developed a model to educate the nursing faculty, and I also told the management that it has to be include for the newly recruited doctors also has to be taught about the proper catheterization. The catheterization may look very simple, but if it is not done, it will cause a lot of morbidity to the patient, and they will be suffering their lifetime. Even today I am doing one patient who had today I am doing one urethral dilatation. His patient got admitted for the CVA, and the catheterization was done, and post catheterization urine was not draining, and 2 years back, and we had to manage with him, and he is on regular follow-up with us. He is on regular, he is a hemiparesis patient, and bringing the patient is difficult, but he has to come and meet us regularly for the urethral dilatation. We have developed one. To develop this, and they had formed this, and they used to insert this catheter when how long the catheter has to go inside, and where the balloon will be inflated, and if it is not inflated in the proper site, what will happen. So they are educating them. Now recently we are seeing less number of cases. Is a normal urethra and normal case. This patient, they have a one small, I appreciate the nursing students who developed this very well. The patient is having a stricture where if you pass the catheter, catheter do not go beyond that. And this is where the post-TRP cases, they will have a lot of, the prostatic cavity will be more, where the coiling of the catheter can happen and the catheter may not be in position. So though it is a very small procedure, it has to be done properly, and otherwise it will lead to a lot of problem. I thank you all for the opportunity. I request I thank the nursing department. They are doing this for your students, and I thank you very much. I think I prefer to take my questions after Ganesh's lecture, because in every meeting after the first speaker's speech, the question and answers takes a lot of time, and the second speaker does not have much time to speak. I request Ganesh to come and talk. We'll have that questions together.
Respected senior consultants and my dear colleagues, so this is a very interesting topic which doesn't restrict itself to one particular department. It goes beyond departments and various specialties. So today's speak is about restless bladder, the understanding about what is happening with the overactive bladder. By definition, overactive bladder is a chronic condition in which the bladder starts to contract too early when it is filling with urine. So there are three components here. Patient has frequency, goes to washroom often. There is urgency, and which can be accompanied with or without urge incontinence. Sometimes the patient comes with severe nocturia where the patient wakes up frequently during night time. So the three main components, easy to remember, FUN, fun, remember fun, frequency, urgency and nocturia. These three things are components of urge incontinence. The International Continence Society defines overactive bladder as urinary urgency usually accompanied by frequency and nocturia without urge incontinence in the absence of, that is very important, in the absence of UTI or other pathology. So there should not be any secondary pathology. Suppose a patient is having prostatic enlargement and these symptoms, we classify it as prostatism. Patient has a UTI with these symptoms, it is because of UTI. There should not be any pathology, and per se the patient should be having all these symptoms. OAB is an idiopathic situation where bladder contracts erratically and it's out of control. So here the bladder becomes a master. A sufferer becomes the slave of bladder. So patient is forced to map the restrooms. They will have Google Map. They will be forcing themselves to look for the restrooms in public places on priority basis so as to avoid any embarrassment. So in a normal bladder, the detrusor muscle contracts when the bladder is full. Whereas in an overactive bladder, the detrusor muscle contracts when the bladder is not full. Only 50 ml of urine, the patient can't hold the urine. There will be a sudden urge, patient will go to restroom for voiding. So it's a huge topic. I'm trying to make it very small. It's undergoing revolution every year in terms of definition, guidelines and therapy. So here, overactive bladder translates into agony, anxiety and very high expectations. If the frequency of urination is more than 8 times during daytime, there is a very high chance of having overactive bladder. There is a sudden strong desire to urinate, which is very difficult to postpone. There is a sudden involuntary loss of urine. Patient suddenly passes urine on the floor itself before reaching the washroom. Patient awakens more than 2 times during night time to pass urine. So here the most important symptom is urgency. OAB burden is very huge in the society actually. It significantly affects the quality of life. What we see in clinics is actually the tip of an iceberg. Less than half with bladder control problems actually see a bladder. Why? What is the reason? So we have 3 reasons. The most important reason is embarrassment. They feel embarrassed when they say that they are going to have urine leak, so they don't want to see a doctor. There is a low expectation from therapy. Treatment கொடுத்து என்ன சரியாக போகுது வயசாயிருச்சு. So there is a very low expectation from therapy. They think that it's a normal part of aging. We are getting aged and so we have this symptom. And most importantly, women continue to live with it. They think it's a process which is happening with them and they continue to live with it. They are silent sufferers. Overactive bladder is a disabling condition significantly affecting various qualities of life, like physical qualities affected, psychological aspect of patient is affected, occupational and financial aspects, social aspect, and even sexual aspect is affected. So here is a case capsule where Mrs. Devi, who says that my husband and I don't go out very often because of my problem. If we do go out, let's say to a departmental store, the first thing that I look for is the toilet. If I can't find one, I leave the store. That's how serious the problem is. It's very commonly heard in clinics actually. This is how they come for presentation. It produces physical problems like unpleasant odor, skin rashes in the groin, frequent falls during night time that happens in elderly people, and sometimes they have insomnia also. Psychological problems like loss of independence. They are dependent on someone. There is fear of embarrassment. Sometimes the depression is so severe that even they get suicidal tendencies. It affects their career. Their day-to-day career is affected. Social problems like decrease in the social interaction itself. Somebody going to gym, suddenly they stop going to gym. They decrease their social activities outside. They decrease their hobbies. They start traveling less and less. This is another case study where Mrs. Mangai, who is 57-year-old, has said that having this problem is really bothersome. For instance, I totally avoid taking a metro rail service for my work because I can't ask the driver to stop somewhere when suddenly I have the urge to pass to toilet. Also, I always wear a dark clothing. Many of these people prefer wearing dark clothing because they don't want to show outside if there is going to be a leak. Characteristically seen. There are sexual issues because of depression and because they feel that they have smell in them, avoidance of sexual contact. Occupation and financial problems like job loss, change of job, all these things do happen and it's a vicious cycle. There is initially depression, absence of work, isolation, guilt, and finally it goes on and on. Studies show that the quality of life is really low. Now, let's discuss certain clinical scenarios pertaining to various specialties. And this is a neurology case, a 70-year-old gentleman diagnosed with Parkinson's disease. There is daytime frequency urgency. There are frequent falls during night time. Now, how to proceed? So here, basically, the pathogenesis is absence of dopamine, which all of us know. So degeneration of dopamine producing cells in the brain remove the inhibitory control over the urinary bladder, resulting in something called as detrusor overactivity, which indirectly means that there is involuntary muscle contractions. The prevalence of this particular disease in Parkinsonism is about 27 to 85%. Initiation of treatment does not require any extensive workup. You just need to do a urine routine and culture sensitivity to rule out infection, get an ultrasound done to rule out any prostatomegaly if the patient is a male. Very important thing, look for post-void residual urine. After passing urine, how much urine is remaining inside, whether the patient is able to empty the bladder completely or not. Then we do a simple test called uroflowmetry. The urodynamic study is not required in all cases. Now let's move on to what are all the treatment aspects which we do in such elderly people. Most important thing is lifestyle changes. We ask them to limit the fluid intake before going to bed, reduce coffee intake, reduce alcohol intake. There are various behavioral therapies, pelvic floor exercises and bladder training exercises. Anticholinergics are the kingpin, but recently we have started using beta-3 agonist. The recent class of medications are called as beta-3 agonist. We have to identify the right patient for the right therapy. So what we prefer here is if the patient is going to have high post-void residual urine, the patient is an elderly man, then it's better to restrict anticholinergics because there is a high chance of retention. So behavioral therapy, as we said, is very important. There are a lot of anticholinergics. They started inventing the next drug. They kept on inventing newer drugs. But the side effect profile remained the same. So they changed the goalpost. They started hitting the beta-3 receptors and they got a new drug called as mirabegron for overactive bladder. So wonderful drug with low side effect profile, good efficacy and very important low discontinuation rates. Started to be used in Japan in 2011. It came to India in 2017 and has been used extensively here. Only one important warning, it can't be used in people with renal failure or elevated creatinine, so should be avoided in people with elevated renal parameters. Urgency, leakage, nocturia, overflow, everything is reduced here. The mechanism of action is it activates the beta-3 receptors on the bladder wall. It inhibits the afferent signals. So you don't have any urgency, frequency, everything comes down. 50 to 60% of people usually respond well. More importantly, the bladder capacity also increases. The bladder tries to take in lot of urine inside and stay quiet for a long time. The strength is about 25 milligram to begin with. 25 milligram, a single dose usually does. In people with severe symptoms, especially young people, we can go till 50 milligram. The good news is that this particular drug, mirabegron, has less dry mouth, less constipation, less urinary retention and less blood vision. All these are side effects of anticholinergics, but can't be used in pregnancy and in renal failure. It's cardiovascular people, even if cardiovascular people are going to have the issue, it's very safe to be used in people with cardiovascular problem. Mirabegron improves the quality of life, treatment satisfaction and presentation in patients with overactive bladder. The study is called BELIEVE study. We can say that the drop-down rates are very less. People who are started on anticholinergic try to have the side effects of anticholinergic usually, like dry mouth and constipation are very common in anticholinergics. So slowly they stop taking these medications. But people who take mirabegron, they continue taking it because these side effects are not there. Moving to the next department, diabetology and endocrinology. Here is a case of a 45-year-old female with diabetes type 2 past 10 years. Patient has been recently started on dapagliflozin, which is a SGLT2 inhibitor. There is an increase in frequency, nocturia, urgency, and very important dysuria. Now here are few aspects. The diabetic detrusor overactivity is a common complication. They have overactive bladder, very important. So added on to that, we have started, somebody has started dapagliflozin. So this particular drug, dapagliflozin, produces glycosuria. It reduces the blood glucose and increases the glucose in the urine actually. So which produces two things. One, the patient will develop osmotic diuresis. There is a lot of glucose in the urine, so there is going to be a lot of urine to be flow. Then the patient has a very high chance of developing urinary tract infections. A lot of glycose or glucose in the urine will invite the bacteria to produce UTI. So better to avoid SGLT2 inhibitors in people who are going to have urinary problem, especially elderly people. So finally, diabetic people, though they have detrusor overactivity initially, they end up in having something called as a atonic bladder. The bladder stops contracting, it starts holding lot of urine inside, becomes a huge bladder. Patient doesn't have any pain even in times of retention, we call it as a chronic retention, and still patient have incontinence. This term is called as pseudo-incontinence because the overactive bladder takes in lot of urine inside and it's just something like a overhead tank overflowing outside. So we call it as overflow incontinence. Like it's not a true incontinence. Bladder has become full. Now it doesn't know where to send the urine outside, so urine starts leaking out. That is called overflow incontinence or pseudo incontinence, very common in atonic bladder. Once again, what I said here is, first thing is fluid and dietary management, which we have already discussed. Anticholinergic drugs are useful in the early stage of overactive bladder and diabetic, which have their action on M2 and M3 receptors. Here there are two groups of anticholinergics, very important here. One we have the tertiary amines, the other one is quaternary amines. The tertiary amines, they have very high level of lipid penetration. They penetrate, they are lipophilic. So they get absorbed and sometimes they may reach and breach the blood-brain barrier. They go inside blood-brain barrier and produce CNS symptoms like cognitive dysfunction. but they are very good medications because they are absorbed very easily. Typical example is commonly used medication like darifenacin, solifenacin or tertiary amines. Oxybutynin is also tertiary amine. The second group of medications are quaternary amines. Quaternary amines have very less side effects. They don't have blood-brain barrier penetration, so can be safely used in elderly people. The typical example is trospium. Trospium chloride is a wonderful drug which doesn't have CNS side effects, can be used safely in elderly. So all these are various medications: oxybutynin, tolterodine, solifenacin and darifenacin. Very important, the common side effects which you have to be aware in people who take anticholinergic drugs are, they have dry eyes, blood vision, constipation and dry mouth. These are all common symptoms, and that is the reason why 80% of patients, they discontinue the treatment after 3 months. We should be very careful that these people are very prone for acute urinary retention because of anticholinergic effect. It goes to the other end of the spectrum and finally they don't pass urine at all. They go for retention. Sometimes they may go for intestinal obstruction also because the cholinergic nerves are blocked in the intestine can't move, they have constipation, they may end up in subacute intestinal obstruction. Moving to the next department, gynecology department, where the medication is frequently used, anticholinergics are frequently used. Here is a case who is a 35-year-old female with recent inability to control urine, especially while coughing and sneezing, there is a urine leak. Whenever the patient coughs and sneezes, there is a urine leak. And there are occasional bouts of urgency, urine leak before reaching the washroom. So these two symptoms are present. Now comes the question, is it really overactive bladder? No, this is not overactive bladder. This is called mixed urinary incontinence. So here the patient is having both stress urinary incontinence and urge urinary incontinence. So here I have introduced a new word called stress urinary incontinence. So what is stress urinary incontinence? Here there is leakage of urine during increase in intra-abdominal pressure, like coughing, sneezing, there is a urine leak. That is a different entity. The pathology is different and the treatment is different. The second thing what we are dealing now in this particular presentation is urge urinary incontinence. Sometimes people have both the problems, stress and urge urinary incontinence. Right. So here there is a very easy way of looking back for things which may produce urinary incontinence in women. We remember by an eponym called as diapers. Diapers, D for delirium, if they have delirium or confusion, if there is infection, if there is atrophic vaginitis also, there are symptoms which mimic an overactive bladder. Some pharmacological agents, especially alpha adrenoreceptor agonist, and psychological factors like depression, dementia may produce overactive bladder. Excess urinary output, especially people who take Lasix, people who are on diuretics, they may be passing urine very frequently, so very important to take history about that. Restricted mobility, very important, stool impaction. So you should look for stool impaction by doing a rectal examination. It's actually a spectrum. At one end of the spectrum you have stress urinary incontinence, the other end you have urge urinary incontinence. These two may coexist together in certain people. The pathogenesis is different. The tools of conservative therapy are, one is behavioral. You teach them to do pelvic floor muscle training. The name of the exercises are Kegel's exercises. Teach them biofeedback techniques. There are few devices which can be helpful in these people. There are peripheral electric and magnetic stimulations available and pharmacological therapy. This is called as a voiding diary or a bladder diary, which is being given to most of the patients who have these issues. We ask them to properly write when they take an intake and when the output is there, what is the total volume of output, how many times they pass urine, complete record for 1 week duration, so we know what is actually happening with them. It's like staying with them in their own home and seeing how frequently they go to the washroom. Bladder training is very important. Bladder is an organ which needs to be taught. Gradually increase the void interval and teach coping stress. We have to teach them how to hold the urination. Pelvic floor muscle training, strengthen the pelvic floor muscles to improve the bladder stability. Exercises are there for overactive bladder. These are vaginal pessaries which are available, and these pessaries prevent the cystocele or descent of bladder down. Sometimes they are useful to be or they are placed inside the vagina so that they have a small projection which will be controlling the urine leak by pushing the bladder neck. Patient can place themselves inside if they get trained adequately. This is a wonderful drug, duloxetine. Along with the routine pelvic floor muscle training, if you put them on duloxetine at very low dose, this controls the serotonin and norepinephrine uptake in the brain and increase the power to contract. So the sphincters become more powerful. So stress urinary incontinence is relieved in 50 to 60% of people when pelvic floor exercises are combined with duloxetine. Moving to the pediatrics department, the next common department where the urinary issues are seen there, I will show you a very small video. These are all the various poses in which we see children with urge urinary incontinence. So they put their thighs together, they sometimes sit down and they try contracting their thighs together, putting their thighs together and try to contract the urine. We call it as P dance. P dance or urinary dance. And this is, once again I'll play the video to show it. This is how. Here there is a trainer, child trainer who is mimicking how these children behave. Typically they sit down like this. They try to contract the urethra so that they can prevent the urine leak. Right. And this is given a name called as Vincent's courtesy sign. The sign is called Vincent's courtesy sign. This is a case where there is a 8-year-old child who often goes to restroom in the schools. Undergarments are soaked with urine, smell of urine. The typical posture adopted by the child is this posture called as Vincent's courtesy. The wonder drug in children usually is the anticholinergic oxybutynin. Started at a very, very low dose, 2.5 milligram, usually as a BD dose. There is an immediate release preparation where the effect is very immediate so that the child feels better immediate. There is an extended release preparation where we can reduce the number of times taking medication, taking one simple dose of 5 to 30 milligram per day, send the child to the school. This child doesn't have much of complaints from the school. There are transdermal patches. We can stick the patch and send the child to school. It stays inside for 2 to 3 days. The patch can stay in the same place so that the child will feel comfortable. There is less amount of urine leak. The advantage of having the patches, less dryness of mouth is seen with the patch. In other things, the patient has increased anticholinergic side effect like dryness of mouth, but transdermal patch has less of dry mouth as side effect because it bypasses the liver metabolism. The primary adverse effect here is pruritus, itching and erythema. The other administrative forms are rectal forms. Sometimes if the problem is going to be very severe, we put it inside the bladder called as intravesical oxybutynin. And finally, the worst issue which a child can face is bedwetting, called as nocturnal enuresis, called as bedwetting. It creates a lot of psychological implication and impact in the child. The child feels bewildered and humiliated, and it feels it's very different from its peers. It's often teased and bullied because of enuresis. It declines to participate activities and overnight stay somewhere in the family or friend's house. It worries their bedroom smells always unclean and doesn't allow any of the people to come into the bedroom. The child is aware of enuresis results in extra work and expense of their parents. So child thinks that she is burdening her parents. The primary pathology here is a hormone called as vasopressin. So vasopressin should be there adequately during the night time. If the vasopressin levels are going to fall during the night time, that produces nocturnal enuresis. So here the main treatment comes in the form of giving vasopressin. Desmopressin is a human remake of vasopressin. We can give behavioral therapy in the form of moisture alarms. We set the alarm in the underdress of the child. So whenever the dress becomes wet, you get an alarm. It forms a form of conditional technique so that the child wakes up immediately whenever it wears the underwear. So it can help in 65 to 100% of people many a times. If the child is going to be less than 5 years, just we can teach the child. 5 to 7 years, vasopressin will help. Here comes one more wonderful drug, which is a tricyclic antidepressant, imipramine. So imipramine is a tricyclic antidepressant, which is very much useful in nocturnal enuresis. So vasopressin plus imipramine helps in adolescent people. Desmopressin is the only drug which is given in high dose in children and low dose in adults. All other drugs we give in high dose in adults. So this is the only drug which is given in a very high dose in children actually and low dose in adults. But we have to be very careful because the medication, if not given properly, the child has to be advised to take less of water after taking medication. Otherwise it will produce dilutional hyponatremia. the sodium levels will fall down and the child may develop seizures. So we have to be very careful in giving desmopressin. Imipramine is the most important tricyclic antidepressant which is used. Then moving on to neurosurgery department, we get cases from neurosurgery department in the form of myelomeningocele, tethered cord syndrome, or even post-spinal trauma. If the trauma is above the T7 spine, then the patient usually has a detrusor hyperreflexia along with smooth sphincter dyssynergia. Sphincter also becomes dyssynergic, detrusor becomes hyperreflexic. If the injury is below the T7 spine level, then we have detrusor hyperreflexia with sphincter synergy. So here we need to do a test called as a computer-based analysis of what is happening in the bladder. That is a urodynamic analysis. It can say what is happening with the bladder muscles, what is happening with the bladder outlet, and what is happening with the urethral sphincter. So bladder has a mind of its own. It's very careful and delicate balance between the behavioral therapy and pharmacotherapy helps patient's mind to win over the bladder. So we have to win over the bladder and the bladder should not win over us. In refractory cases, what to do? The patient doesn't respond to medications. Finally, we take the knife. We start doing surgery for these people who doesn't respond to medication. There are three options. Do a cystoscopy or an endoscopy. Inject botulinum toxin or Botox. Sacral neuromodulation. Finally, augmentation cystoplasty. So OAB is truly a jigsaw puzzle as the pieces of puzzle are getting organized. Botulinum toxin is the final option. The common toxin which is being used in our practices. There are 7 variants actually. It acts by inhibiting the acetylcholine release at the presynaptic level so that the bladder contractions will totally stop after giving injections. But is it useful for long term? No, it's not useful for long term. The injection is effective for 6 months to 1 year duration. The common toxin which is used is Ona botulinum toxin A. So it is injected in the form of doing a cystoscopy. We do cystoscopy and inject at 30 different areas. We avoid the trigone area, which is the initial area. We avoid the dome of the bladder. And apart from that, we give in 30 different areas, 30 to 40 areas. The outcomes are excellent actually. And the patient has these outcomes only for the time period of around 6 months to 1 year. After that, we have to once again start anticholinergics or go for a second dose. Finally, if nothing works, we can do sacral neuromodulation where we place a small electric probe in the S3 level of the sacrum and have an electrostimulator in the hand. This keeps stimulating the nerves, thereby the overactivity comes down. Or we can give the patient percutaneous tibial nerve stimulation. Here we stimulate the tibial nerve which has the root value L4, L5, S1, S2, S3. So when these nerves are stimulated, the overactivity comes down. So patient visits the particular clinic where the stimulation is done. For 30 minutes, she takes the stimulation. For 12 continuous weeks, the stimulation is done. The effects are 60 to 80% helpful in bringing down the overactivity. So surgical management, finally, there are various surgeries available. This is called augmentation cystoplasty, where we open the bladder and cover the bladder with ileum so that we increase the capacity of the bladder and prevent the overactivity. This is one more procedure called as sacral dorsal rhizotomy, where we cut the dorsal nerves of the sacrum, which are responsible for the overactivity. So finally, bringing out everything to summary, if the patient is a very young chap with very less post-void residual urine, we can start them on anticholinergics, which are excellent drugs, very cheap to use. The patient is going to have high post-void residual urine. Patient is a very elderly with cognitive dysfunction, put them on beta-3 blockers. If the patient is a child with nocturnal enuresis, put the child on desmopressin or arginine vasopressin. Be careful to be aware of hyponatremia. Tell the child to take less water. If everything fails, then botulinum toxin helps. And finally, surgical options are also there. Thank you. That is a famous Brussels statue where you can see the child pee in the Brussels. Thank you. Start with Dr. Kathamuthu sir.
Ganesh had a fantastic presentation and it was very informative. I also learned a lot of things. Yes, sir.
The case which you presented, you put the cell cultured tissue and then you created a scaffold. And after that, what happened to the patient?
The patient was on the catheter for 10 days, and after that we removed the catheter. Patient voided urine well. Actually, it is 20 days after it is 1 week after the catheter removal, the patient came for the follow-up. The patient voided urine well, he is happy. We don't have a long-term follow-up, we just, the procedure was done about 3 to 4 weeks back only.
The way I asked is, basically this fellow is a paraplegic.
No. The first patient is a paraplegic. Oh. That is a urethral diverticulum. The second one is a college student from USA.
So the paraplegic, what happened?
So we have done diverticulectomy with internal ureterotomy.
And then we put him on CAC, is it?
I placed him on CAC, but the patient was not willing to go for a CAC because he was taking exam. So he wanted to be on the catheter. So after the diverticulectomy and internal ureterotomy, we kept him on catheter for 3 weeks. After the 3 weeks, we removed the catheter, and then he wanted the catheter to be reinserted. He wanted to be on the catheter for some time till his exam is over. He came for follow-up twice, and we have changed the catheter. Catheter went easily without any problem. There is no wound leakage or anything.
So can he go back to CAC in the future?
I hope that he should be able to go because the catheter was going freely without any problem. So there should not be any issue in CAC, I believe.
All right. Okay.
Yes.
I have a question for Ganesh. Yes, ma'am. Yeah, regarding OAB, I think both topics were so nice we could relate. One as a clinician, the other one as an individual as well, this OAB. So what is your say on yoga, lower body yoga and how long you will be doing pelvic floor exercises without medications?
Yes,
how
ma'am.
can we wait?
It forms a very important part because behavioral therapy and other alternate therapies also play a very good role in actually curing these patients. So yoga is extremely useful in curing these or bringing back these patients from medications. You should not be dependent on medications always. You should have other alternative ways of coming out from the medications. Yoga is an excellent way. Acupuncture therapy is also really good. Magnetotherapy is really good, placing these people on magnetotherapy. So definitely yoga helps, ma'am.
Ganesh? In all of your slides, the patients suffering from overactive bladder are all women now. You have not shown even one man.
Overactivity is usually associated with prostatomegaly, prostate enlargement in elderly, and in young people, definitely there are cases, but the numbers are very high in women, sir. That is the reason. That is a very big topic, sir. Talking about prostatomegaly and overactivity itself is a separate topic.
I really appreciate Dr. Kathamuthu, who allowed his junior or colleague,
Yes, sir.
Dr. Ganesh
Definitely, I am very much thankful,
to have
sir.
a very lengthy talk. It was possible because of the
Because of
taking away the question and answer session
Yes.
in the initial stage.
True, sir.
And always your talk is covering a large amount of
Thank you, sir.
this,
Thank
this
you,
thing,
thank you.
and it is filled with information.
Thank you, sir.
We
Thank you.
cannot forget your speech on erectile impotence and all those things last
you,
time.
sir. Thank you, sir.
Everybody was spellbound.
Thank you, sir.
And Dr. Kathamuthu, for that urethral stricture, it was just like hourglass. A simple cut, would it have resulted in the same thing? Okay, because this buccal mucosa fails in most of the urethral hypospadia cripples.
Yes, sir. But in this case, it is in the bulbal urethra. So, young man, unmarried, and actually, the studies have shown excision and end-to-end anastomosis near the bulbar urethra. There is a rare chance of erectile dysfunction. So, we want to avoid that. And visual internal ureterotomy is having a high failure rate alone. So, this is a novel technique that is coming up. And but we don't have any long-term studies or long-term follow-up data. But so far, whatever procedure, whatever patients that are done, they are having good results. We have to wait for the long-term results.
What is the cost involved?
The cost of this cell is about 1.5 lakhs.
And you said urethral diverticulum is a very rare condition, but in government hospital we used to get 1 or 2 cases per year.
But
we
what-
call it anterior urethral valves. Even though there are no valves, the corpus spongiosum becomes deficient and it bulges like a...
Whatever I searched in the literature is like that, and moreover in my 15 years, this is the second case I am seeing. We saw about 9 years back, myself and Palisam sir did one urethral diverticulum in a child which is a congenital, and this is the first case of acquired diverticulum I am seeing. And also in the literature also it is reported as it is a very rare condition. Maybe it is common in children but not in the adult. And urethral diverticulum is more common in women. In women it is common, and in men it is not very much, not much cases are reported in the literature.
In pediatric surgery, it is the opposite. In children, boys only we get cases in the anterior.
But in adults we don't see that.
And the Vincent's posture you quoted, it is not peculiar to the control of urine. It is very common in habitual constipation.
Yes.
When the children
They exist
don't want
together.
to pass
Yes,
motion.
yes, sir. These sphincter dysfunctions usually exist together, sir. True, sir.
I again appreciate you for the large volume covered in the talk.
I know that Ganesh talk will be always, he is the star speaker of our department.
Yes.
I know that he will sweep me if I talk after him. Everyone will go away. Once his talk is over, everyone will leave the hall. So I thought I will talk first and then we will make Ganesh to speak. Thank you all.
And what about the mid-urethral slings?
Stress urinary incontinence itself is a huge topic, ma'am. Mid-urethral slings definitely are the kingpin in treating the stress urinary incontinence. If we start about TVT, TOT slings, or the rectus fascia being used as a sling, or the recent invention of using the muscle, the own muscle can be injected that in the mid-urethral level. Itself is a very big topic, so I have restricted myself because we are including all departments here. Thank you, ma'am.